behavioral health was created to lower overall employer health coverage costs and pass savings along to employees. At the core of this mission was the idea that if clinicians oversaw other clinicians, abuses such as years of daily psychoanalytic therapy, or patients who were locked away in state mental institutions for most of their lives would become a thing of the past. Those of us who entered managed care early on in its inception were passionate about ensuring that our patients received good clinical care. We had the power to do something about it, and we did. After all, money talks, and once you threaten not to pay for ineffective treatment, people are surprisingly willing to change what they're doing. With strict oversight from these managed care companies, providers soon began to utilize the tenets of a short-term treatment model. Over time, patients were enjoying faster symptom relief at lower costs both to them and their employers. Patients returned to work and to their lives faster. Our clients' productivity levels increased and staff turnover in the use of disability benefits decreased. We did our jobs and we did them well. After several years, we sensed a shift in our mission. The goal was no longer to ensure that our members received the most aggressive and progressive treatment. We noticed that our performance was being reviewed against how much care we authorized. We got the message very quickly that those who authorized treatment too freely were either disciplined or replaced. We knew to cover ourselves by sending the more complex cases to the psychiatrist to review so that their name would be on the authorization, not ours. As the years went on, more managed care companies entered the market, and as they merged to create larger, more powerful companies, competition for contracts became fierce. You see, how rigorously a patient's case is reviewed is solely dependent on two things. One, how much profit is built into that contract. Number two, what expectations does the employer have about how they expect their employees to be treated, and whether this level of treatment is reflected in the price of the contract. This all translates into whether your treatment is covered or not. I served as manager of the Health Plans Division of APS Healthcare and was later promoted to Vice President of Clinical Operations for Magellan Health Services. I left because I was constantly pressured to push the ethical boundaries of my profession. I am a clinician, first and foremost, and I became so because I want to help patients, not find ways to deny them care. It was my job to control the number of authorizations my units issued each month. I'd like to describe some of these methods that we used for you, particularly as they pertain to eating disorders. Now that I sit on the other side as a provider of treatment, I can see the devastating effects these methods have had on the entire system. In all actuality, for all the rigmarole the insurance companies go through to contain costs, it does just the opposite for them and for us, especially when it comes to the treatment of eating disorders. Tactic number one, managed care is short-sighted, and it worries more about its monthly authorization numbers than on long-term success rates for consumers. When you bake a cake, you usually bake the cake at 350 degrees for about an hour. Managed care believes you should turn the heat up to 500 degrees and bake it in half the time. This may result in a cake that looks done on the outside, but it will not be fully cooked on the inside. And if left out on the counter, it will collapse into itself because the center isn't solid and can't sustain itself when it comes out of the mold. I offer this analogy to illustrate how managed care pushes providers to expedite treatment of eating disorders to save money. Patients must be refed first to gain access to their emotions, which takes time. Once they are feeling again, they need time to gain insight into how their emotions are playing out on their relationship with their food. If this does not occur, the old coping mechanisms are reactivated once everyday stressors are reintroduced to their lives, like a return to work or school. Patients have no option but to fall back on their old patterns of behavior. Success in this particular area cannot be rushed. With every failed episode of treatment, Most patients will internalize their treatment failure. They think, I must be failing at my eating disorder because the insurance company doesn't think I'm sick enough, and they up the ante. They feel like failures themselves when they are unsuccessful in each attempt to control their disease, and they feel helpless. Renfrew, Maryland has two 14-year-old girls in our program right now who were recently denied continued coverage in our partial program after just 2 weeks of treatment. We had no choice but to step them down to our intensive outpatient program, knowing full well that they were being set up to fail. Sure enough, both patients lost weight after just 1 week and now are in need of readmission back to our partial program. Managed care does not listen to treatment providers, which is wrong and difficult to understand. It interrupts a critical treatment process that works if it's allowed to work. With every failed course of treatment, the possibility of recovery for these patients becomes harder and harder to even imagine. Tactic number 2. Managed care uses inappropriate medical necessity criteria. Only in the last 5 years have managed care companies begun using eating disorder criteria. Some don't use them at all, and none of the ones managed care uses match the criteria set forth by the American Psychiatric Association. Using regular medical necessity criteria for eating disorder cases is like comparing apples to oranges. Only authorizing treatment when a patient becomes suicidal, homicidal, psychotic, or in need of detoxification couldn't be further from what the issues are in eating disorder treatment. It is absurd and dangerous for a governing body not to speak the same language as the credentialed providers it has hired to deal with these very serious, in fact, life-threatening issues. Tactic number 3. Managed care stipulates a certain number of treatment days care managers are allowed to authorize. The current trend is 2 to 3 days, and they often have unrealistic expectations as to what can be accomplished in this very short time frame. Sometimes care managers won't authorize further care, and the cases are sent up the managed care food chain for a higher level of review. This can take 1 to 2 unauthorized days, which leaves patients at risk of having to pay for those days out of pocket, which can be quite costly. Several problems result from this tactic. Number 1, generally, most patients can't take the strain of going through this process every few days, and they voluntarily terminate treatment. Number 2, it is distracting for any patient, and they are unable to engage in treatment for fear of opening up and having to leave. As a practice, this really drives costs up for both sides. Managed care is paying for multiple clinicians and psychiatrists to review one case through multiple levels of appeals. On the provider side, we too have to pay multiple different clinicians and psychiatrists to go through this process. To do this every 2 to 3 days results in a shocking loss of revenue for both sides. Is it any wonder that our premiums and the cost of care escalate because of all this craziness? Tactic number 4, managed care creates the catch-22. If during a review we indicate the slightest improvement, for example, let's say the patient follows her meal plan the previous evening, or has a really productive family session, the insurance company will often stop authorizing treatment for the patient, saying progress was made and she can now be treated safely on a lower level of care. On the other hand, if the patient isn't making a lot of progress, they may deny coverage, saying the treatment plan is not effective. They like to say that they are consumer-focused, but they need to understand that treatment of eating disorders is not a linear process. They need to learn about it and understand it, rather than hold on to counterproductive review strategies. Tactic number 5, managed care relies on numbers to determine care. Managed care focuses on percentage of ideal body weight to review care. The problem is this: it effectively eliminates patients who struggle with bulimia or binge eating disorder. These patients need treatment just as much as those suffering from anorexia, but because they look okay on the outside, they are not reviewed by the same consistent criteria. This is discrimination. Weight is by no means the correct or only indicator of a need for treatment.